Yes.
Yes.
Over to you,
So
Gaurav.
thank you. Very good evening to everyone. So I have no financial interest, and I'll just start by showing you a small clip here, um, which will give you an idea of what why I'm giving this talk. Now, this is how we many times are obviously injecting our lenses. Most of us would be doing that. This is a nice, and you can see it's in slow motion. It went and hit the angle over there, and you can see that big bleed. So you'll have these sudden injections, and I've had them go through the PC sometimes. I've had them go hit the angle or cause a zonular dehiscence when they go into the sulcus. So these unpredictabilities are there with our conventional injector systems, and you need a better system. You can see here this patient was on anticoagulants, and we had a very tough time. We had to intervene twice over a week or 10 days because it would not stop, and we had a big clot form over there. And later on, here we managed it, but later on it went on became bad. Another situation where we are going ahead with a injection. This is a wound assisted injection. These are all non-preloaded lenses, and sometimes these things happen with preloaded also, but things have been getting better over the years. You can see that it's a very tight lens, and as I'm trying to inject it, this is probably from 2015 as I can see, but you'll have a funny situation. Can you see that? So, these unpredictabilities have pushed us to get better and better with injector systems. And today we don't see many of these things. Most of these things have become much less. Most manufacturers have gone on to come up with very good injector systems. Amongst them is the Hoya. I remember when somebody from Hoya used to come to me about 7-8 years back, and they would keep trying to promote. I used to love their lenses, but I never liked their, and I like to do hydroimplantation. So I used to keep telling them that the day you have a shooter, I'll start using your lens. And then about maybe 5, 6, 7 years back, they came up with the Multisert, because then it became possible to use. The lenses have always been great, but the injector system previously was always the unfolder type, and then they introduced this, which is a revolutionary injector system. And from that day onwards, I've been very happy to use all the gamut of Hoya lenses, because the injector system is amongst the best. So it allows you to do a single-handed push, or it allows also to do with the same injector you can do the unfolder kinds of rotatory thing, which is very, very controlled, and both systems are excellently controlled. The other advantage I find is that the incision size required, you don't have to do a wound assisted injection even with a 2.2 or 2 millimeter incision. I typically do 2.2 surgeries for all my machines, and all my standard incisions are 2.2, so you can actually go and deliver the lens into the bag without having to use wound assisted. But if you would rather do wound assisted, you can do that as well. So it's a very controlled delivery system, especially if your bag is dehisced, or if there is a PCR and you want the lens to deliver straight into the, inside the rexus, inside the bag. You don't need to worry about it. Loading and everything is fairly easy for those of us who've used it, and it's very predictable, and surprises are almost none. Even over 1,000 lenses. So as this slide probably tells you, there was a study done in 14 European clinics, and they basically studied how many were broken injector tips and how many complications, etc. Now I'll take you to some of my videos which might give you an example. This was an aborted phaco. Somebody had started doing surgery on a hard brown cataract and had aborted the surgery and referred it to us, and we did not know about the status of the rexis. There was also this fear of a subluxated bag, and we had to deal with this situation 3 days or 4 days after the surgery. You can see here that I'm trying to make sense of what is the situation. I'm trying to figure out if the rexis is intact and how bad is the zonular dehiscence, because the referring surgeon said that suddenly they realized that the bag was not stable and they did not have access to capsular hooks. So I'll maybe run you through this. We are trying to implant capsular hooks in the hope that the rexis is intact, because the surgeon did say that they did not break the rexis. So taking a chance, I'm putting in capsular hooks to stabilize the bag, and I'll not waste much time. But it's a hard brown cataract, and with very low parameters, I'm trying to ensure that this bag does not move too much. I'm cracking the nucleus, and with lateral separation, and rexis is fairly small, and I'm only hoping that the rexis remains intact right till the end. So far so good, and small pieces being created there, and then eventually manage to, the pupil starts coming down. There is a little bit of an iris prolapse happening. So it all happens obviously because these are such challenging surgeries, and even with very low IOP that I'm working with, you can see that these pieces are very hard and big, and repeated viscoelastic insertion there with using viscoat. Now I've reached a situation where the bag is collapsing, so I'm going to introduce the CTR, because once the bag starts collapsing, then the CTR will ensure that even in spite of the capsular hooks, you will have a bag which is more stable, and you can see suddenly things look better with the CTR inside. And then as the pupil is coming down, I managed to get this whole thing out, and luckily we have an intact rexus. Now this is where the injector system comes in. Now you have a bag which is not very stable, and you want to ensure that there are least manipulations when you are injecting the lens. So you go in with it's a 2.2 incision. Now you can see that my cartridge tip is very nicely there. The lens opens very predictably, unfolds very nicely. You don't have to do any maneuvers to get this thing. Otherwise, the maneuvers of getting the trailing haptic into the bag itself is enough to cause the dehiscence to increase. So I find that, in all my situations where the bag is suspect, where there is some zonal laxity, I tend to use, and you can see here that it's nicely sitting there. And on OCT, you can appreciate the lens is very well centered and it's perfectly horizontal there. Another patient here, which was trauma, patient with some trauma and a big iridodialysis. We had to do a dialysis repair. So first I'm going to just get this stained and put the cap iris hooks there. The surgery itself is not very remarkable. Let me take you straight to the IOL injection. This patient also had a dehiscence of the zonules and the bag was not stable, so we are going to put in a CTR and then go with the IOL injection over there. This is the CTR being put, and young patient, and of course later on an iridodialysis repair, but here I'm enlarging the rexus so that my IOL goes in more straight, in a more smooth way. So, and then the IOL injection, I'm distending the bag with viscoelastic over there. I'm sorry, but so this is again my favorite injector system in such situations, that you can have a proper insertion straight into the bag. You can see that even with a small rexus, you are getting a perfect control. The bag does not, the IOL does not open unpredictably. It doesn't get stuck. The haptics don't stick to each other. So you have a very, very straightforward controlled injection and nicely sitting in the bag there. I'll just finish with the last case. This is a patient who had undergone a VR surgery and post-VR surgery with gas in situ, very intumescent cataract which developed very quickly. So we were very worried about a posterior capsular dehiscence in this patient, but we went ahead with a femto-assisted surgery for the rexus creation, and eventually there was almost no glow there except when you twisted the bag a little bit. There's post-RK also. She had multiple RK cuts, young lady of about 45 years old. So there we've got the capsule out of the way, and you can see that here it's a floppy iris, and there is a lot of upthrust from the gas which is there behind. So it was 3 weeks or 4 weeks after the VR surgery. It's a hardish cataract though.
Could we've got one more person.
Okay, so I'm finishing in 1 second now. So the cataract comes out. I'll just take you to the lens injection. There's a lot of upthrust there. I'm sorry about that, sir. So that's gas in situ, and now the IOL injection which will happen right there. So in RK eyes again it becomes very easy because it requires a very small incision. There is no pressure on the RK cuts, and you have a very controlled injection straight into the back, and you can even do a wound assisted, but I prefer to do here a standard injection and then get it in the back. Thank you so much.
Thank you, Gaurav. There's no doubt that this is one of the best injectors in the market today. You have the push type and the screw type in the same injector, and you can choose whichever you like. Yeah, I think Gaurav likes the push type, basically, and not the screw type. And because he does hydroimplantation, so he needs the other hand to irrigate and maintain the anterior chamber. But I think all in all, this is one of the best injectors. Hardly ever do you have an optic-haptic junction crack, or you have an optic crack, or if the lens hardly ever flips. So I found that over the years, I've been using this lens for about 25 years now, but I found it one of the most, apart from the lens, the injector system is really very